Alrighty, good morning, everyone. I do know we are on different time zones, so hopefully still everyone is in the morning, if not good afternoon. Please do know that we are recording these sessions for distribution through the Chagas Echo website. We are excited to have everyone join us today. This session is brought to you by the Rockefeller University, Clinical Directors Network, Texas State University, San Diego State University, and UT Health San Antonio Echo. My name is Maria Gutierrez, and I am with the UT Health San Antonio Echo Super Hub. I have some announcements before I pass things over to Dr. Stigler Granados to continue introductions and the remaining of the session. Just a few housekeeping reminders is that we do ask everyone to please stay muted unless you are speaking. However, during the session, we do encourage everyone to share their insights, share their perspectives, and you can do so by unmuting, raising your hand, or using the chat function. Finally, please do remember that no protected health information is to be shared during today's session. We want to make sure that everything is kept confidential. Today's topic of discussion is the recommendations on how to screen, diagnose, and treat Chagas disease at federally qualified health centers. This is session two of a four-part series. We will be offering 1.5 continuing education credits for providers, nurses at each session. Please make sure to complete the evaluation survey that does get sent out to you. We'll make sure to post that in the chat along with some emails as well. For anyone that is new to ECHO, ECHO stands for Extension for Community Healthcare Outcomes and is a model of lifelong learning and guided practice that connects community-based health workers and a multidisciplinary team of subject matter experts to create community of practice and learning. The heart of ECHO is the case-based learning concept. So we are all learners, we're all teachers. We do want to create a safe space for everyone. We do welcome everyone to please share their own challenges, strategies, resources, and lessons learned with peers and colleagues. And with that, I'll go ahead and hand it over to Dr. Stigler Granados. The floor is yours.
All right. Good morning, everyone. Happy Valentine's Day if you do that. It is, I'm just happy it's Friday. I don't know about anybody else, but I'm grateful it's Friday today. It's been a crazy month, but welcome to our second session this series. We're happy to have you here. We have an awesome set of speakers today, some really incredible people that I'm super excited to be working with. And I'm just going to quickly talk a little bit about the series that we have. The next two sessions coming up, we have two more. We have one on March 14th that I will be doing with Dr. Melissa Nolan. And then we had a change of date if anybody saw previous flyers, but we have May 9th now is coming up with Dr. Eva Clark with people living with HIV and Chagas disease. So these are for credit. So I will have a evaluation link for you at the end. We'll also put it in the chat as well, and you can get CME for these sessions. So I think I wasn't paying attention, Maria, but did you just talk about the echo model?
I did briefly, but go ahead. We didn't go over the
Okay.
principles.
I'm sorry. I was distracted thinking about what I was going to say and wasn't listening. So principles of the model, we usually have didactic followed by case presentations. And I think our Chagas echoes are unique from other echoes in that we tend to sprinkle the case studies in throughout the presentation. So you will have Dr. Hamer is going to give a little intro into Chagas disease, and then Dr. Coyle will follow with some of her expertise and cases that she's seen, with Nancy Jenks following at the end, talking about their experience with the pilot study the pilot program that they have going on. So again, this is sponsored by quite a few different groups together. I was happy to partner with CDN last year. They are sponsored through several other grants like the Stavros Niarchos Foundation, Institute for Global Infectious Diseases. We are also sponsored by the CDC, the Parasitic Diseases Branch. We have a cooperative agreement with them. And full disclosure, Dr. Coyle and Dr. Hamer and I all three have cooperative agreement with the CDC Chagas disease, parasitic diseases branch program, and that is with our program officer, the amazing Dr. Sue Montgomery. So we're happy to be here presenting with this. A little bit more about CDN because they're a newer partner for us, but they're a New York City-based practice with Practice-Based Research Network and AHRQ designated Center of Excellence for Practice-Based Research and Learning and a network safety net of PBRNs. So they're dedicated to improving access to care and clinical outcomes for low-income and medically underserved communities by creating community academic partnerships around research, education, training, and service. So this is a perfect fit for us to be working together on this education for health providers and others on Chagas disease. So this again is just a list of the upcoming sessions that we have in bold block. That's today. Next month, please mark your calendar. If you signed up for this one, you'll automatically be registered for the next one on March 14th and then May 9th, the HIV session as well. So I'm going to present all three of you amazing presenters today and then give the floor to you to take over. I will help moderate the chat as well. So I've got their bios here, and I'll just read them out. Dr. David Hamer, Professor of Global Health and Medicine. Sorry, I have to move my screen over here a little bit. At the Boston University School of Public Health and Medicine. He's also co-lead of the Climate Change and Emerging Infectious Diseases Research Core at BU Center on Emerging Infectious Diseases. And he's also an attending physician in infectious diseases and the director of the travel clinic at Boston Medical Center, PI and co-investigator for several studies of enhanced screening, diagnosis, and management of migrants with Chagas disease and part of two national U.S. Chagas disease consortia. Happy to have you with us, Dr. Hamer, an esteemed expert on this topic. And same with Dr. Coyle, amazing board certified infectious disease, been practicing for over 20 years. Director of the Infectious Disease Service at Jacobi Medical Center in Bronx, New York, and oversees an active tropical med clinic, professor of medicine and pathology at Albert Einstein College of Medicine, extensive experience with trop med, travel med, parasitology, and immigrant health. She's also the site director for GeoSentinel Network, a network dedicated to surveillance and study and movement in infectious diseases across borders. It's also funded by the CDC since 2007. She's very widely recognized as an expert on larval tapeworms, neurocysticercosis, and echinococcus. Did I get that right? I can never say that word. Am I close? Um, Serving on both national and international committees for these pathogens. She currently serves as a counselor of ISTM and is also an associate editor for the Clinical Infectious Diseases and an editor for the CDC Yellow Book. And after I've read both of your bios, I am tired and I'm so always impressed at everything that you do. So, um, I'm also going to, okay, so, and for Nancy, who is an amazing partner working on Chagas disease, um, she is a family nurse practitioner in internal medicine at Sun River Health, specialist in travel med, and particular interest in trop diseases and immigrant health. She has been also the GeoSentinel site director at SRH for over 20 years, tracking infectious diseases and migrant populations. She's published in the peer-reviewed medical literature on topics that include hepatitis E in travelers, enteric fever, strongyloidosis. I can't ever get that one right. I'm just going to say strongy because that's what I usually call it in migrants, MRSA and Lyme disease in immigrant populations. So again, really grateful to have all three of you here. A little bit just about me. I'm an associate professor in the School of Public Health at San Diego State University. I've been doing Chagas disease for about almost the last 10 years now with the cooperative agreement with the CDC that Dr. Coyle and Dr. Hamer are both also on, just raising awareness about Chagas disease, mostly with healthcare providers, but also within the entire world of Chagas disease and public health. I work with the military quite a bit on Chagas disease surveillance and activities and lots of other projects. And I started off by launching the Texas Chagas Task Force in 2015 with my partners at Texas, Texas State University and UT Health, which is how we're all connected together. So with all that, I'm going to turn it over I'm going to stop sharing. I'm going to turn it over to Dr. Hamer to start us off. And again, please put your info in the chat for us so we kind of know who is in the audience. And I will also be helping to facilitate and be a timekeeper for our speakers. Welcome, everyone. I'm happy to have you all here.
Okay, this is not the right, there we go. Okay, well, thank you very much for the kind introduction, Paula. And it's nice to be working with Chris and Nancy on this. And we all have a common bond, which is GeoSentinel, because I didn't have that in my bio, but I'm part of it as well. But today I'm going to be talking about screening and diagnosis of Chagas disease. And let me jump into this. So just a couple disclosures. Because of the volume of Chagas patients we've been seeing, we've ended up working with a company called Kefera Diagnostics on two different projects. One is they're trying to design a test of cure, which was sort of the holy grail for Chagas because we do not really have one right now. And then a rapid point of care test. But mainly we've used this to develop a biobank for well-characterized patients with Chagas disease, before treatment, after treatment, or with cardiomyopathy if they haven't been treated. And then INSECT, which is our acronym for a project that is funded by the CDC Parasitic Diseases Branch, a cooperative agreement, which Paula mentioned, I'll say more about that towards the end of my talk. So this is an outline of what I'm going to discuss. I'm going to talk a little bit just basic epidemiology of Chagas in migrants in particular, brief overview of clinical complications. I'm not going to go into a lot of depth because I really want to focus much more on screening and some strategies for screening and some barriers that you may encounter. And let me move on. So this is showing the global distribution of patients with Chagas disease, World Health Organization map. And the endemic countries, there are about 21 endemic countries, are really South America, Central America, Mexico. But there are a number of non-endemic countries where people have migrated to that are living with Chagas disease. And many of these are in Europe, but also the United States and Canada. In endemic areas, the highest prevalence is found in really the southern cone in Bolivia, Argentina, and Paraguay. And Bolivia in particular has amazingly high rates, high prevalence of Chagas disease in certain parts of the country. This is a different way of looking at this. So this is looking at Chagas disease in non-endemic countries, with the different colors for the volume of infected or estimates of infected individuals. And the U.S., has, because of its size and because of the migration of populations from Latin America, has a substantial burden. But it's interesting, Spain has a lot of Bolivian migrants in particular. And as a consequence, they have, an estimated 47 to 67,000 patients there. There are various estimates of how many people are living with Chagas in the U.S., but around 300,000, perhaps a little bit more than that, is sort of the best available estimate. And then I work in Massachusetts, and we have Maya Carillon, who was my doctoral student and now is working for DNDI. It put this together and basically, sort of tried to estimate based on the country prevalence and the population distribution of people from endemic areas to see how many patients or how many people might be living with Chagas in Massachusetts. And we came up with an estimate of about 5,000. But things are changing, and this is really a fascinating look. There's been a substantial change. The population of Massachusetts between 2005 and 2020 has increased by about 10%. But if you look at the relative distribution of certain Latin American populations, in particular Guatemala and El Salvador, in Ecuador also, there's been a substantial increase in patient populations. And notably, Salvadorians are probably the most common migrant population from Latin America. There's a fairly big Salvadorian community. It's interesting, Colombia is not listed here, but there's actually a lot of Colombians from Medellin. They tend to have lower prevalence of Chagas, but we've still seen a number of infected patients from that area of Colombia. So just a little bit of general background on transmission. So this is primarily transmitted by the parasite Trypanosoma cruzi is primarily transmitted by triatomine bugs, but also there's potential for either bugs or the parasite to be in contaminated food, especially fruit and juices. And so oral consumption can lead to infection, and sometimes that can be associated with a very large inoculum and really a severe illness. What's important is non-vector transmission, in particular mother-to-child transmission, but also potentially transfusion. Because of that, our blood supply routinely, at least in the US, routinely screens for Chagas disease, um, and then potentially organ transplantation as well. So just a few comments on congenital Chagas disease, looking at in the United States in particular, there are an estimated 40,000 women of childbearing age that are infected with T. cruzi. The risk of transmission is somewhere in the order of 3 to 5%. You can see this study down at the bottom. That Doctors Howard and then Pierre Buchan's did a few years ago as a systematic review and meta-analysis, and they basically tried to assess what the pooled congenital infection rate was in non-endemic versus endemic countries. And for endemic, they found about 5% based on 30 studies, and non-endemic a little bit lower, 2.7% based on a somewhat smaller number of studies. So this is just a brief summary of the sort of process of the disease. After an incubation period of a few weeks, there may be an acute infection with a number of different symptoms, including fever, and there may be if there's a lesion, if the initial bite is near the eye, there may be a chagoma. At this point in time, the blood smear should be positive, and PCR will be positive. For those places that can do culture, it may be positive. And then after several weeks, patients progress into a chronic phase, and this can last for decades. And really, I'm going to focus especially on this chronic phase when I talk about diagnosis and serologic testing. Many patients will continue in an indeterminate form with no complications ever, but an estimated 20 to 30% will progress. And again, this may be over a few years or over several decades. And when they progress, the major complications are cardiac and gastrointestinal, either esophageal or colonic. And Karen Byrne, this is a really nice review of the disease from about a decade ago. There are more recent reviews as well. We have seen a lot of patients with Chagas now, and cardiac complications are really a major bane of their existence. These range from arrhythmias to dilated cardiomyopathy, intramural or intraventricular thrombus, sometimes associated with a left ventricular aneurysm that can lead to embolic events, and stroke and other complications. GI disease in our population, because we have mostly Central Americans, it seems like there's less gastrointestinal complications than are seen in the southern cone of South America. As I mentioned, the esophagus and colon are most commonly affected. This is a picture of a megacolon. Patients may be asymptomatic. I mean, when I evaluate a new patient, I routinely ask them about difficulty swallowing, as well as constipation or other GI complaints. So let me say a few words about testing right now. And this is a challenge because in order to make a diagnosis, you need to have two different tests. PCR is not done routinely except for diagnosis of congenital infections shortly after delivery or reactivation of disease in a highly immunocompromised patient. And this is partly because not everybody who's in the indeterminate stage will be PCR positive. So we're therefore dependent on serologic testing. And the challenge is a single positive test is insufficient to confirm the diagnosis. So you really need to have two different tests done. And I'll say a little bit more about this in a minute, but basically, if screening test is done, if this is negative, then we sort of say that patient does not have Chagas. If it's positive, then a different serologic test needs to be done. And once the diagnosis is made, then the workup is undertaken, which perhaps Dr. Coyle will talk more about that. So this is a table that a colleague of mine kindly put together and shared with me. This is a summary of sort of some of the major reference labs in the United States and the tests that they use. And most, with one or two exceptions, are not doing a confirmatory test. So you see, many will do either the hemogen or the Wiener ELISA as the first step, but then you need to find a laboratory that can do the second test. For years, we were using the CDC Parasitic Diseases Laboratory. Unfortunately, they have had to pause testing recently. Hopefully, this will be reopened. Um, our in the Boston area, our tests, our samples go to Quest, and until recently, Quest only did, actually for years they did hemogen. They switched to Wiener a couple of years ago. And then if we confirm, if that screening test was positive, then we would have the lab reserve a sample from the original blood draw so the patient did not have to return to have a second blood draw and then send that to the CDC lab where they would do the Wiener and then a Tessa blot. At this point, because those are not available, that's one challenge. But Quest changed about a year ago or thereabouts, and is now doing a confirmatory test. So they'll do a screen with a Wiener and then the InBios as a confirmatory test. The only other group that I know that's doing that is, I guess, the state of Texas, but also Kifera Laboratories, which has does the Wiener, but also can do a multi-cruci immunoassay and then a test of blood. So finding a place to get the second test done, depending on which reference laboratory you have access to, may be a challenge. So going back to congenital disease, it's really important. I mean, one really important target population are women of reproductive age. And if a mother's already diagnosed with Chagas disease, that's great. Then their infant definitely should be screened. If the infant's born with evidence of congenital Chagas disease, they should also be evaluated. And then if the mother hasn't been screened, but is from an endemic area where she may have acquired an infection, it's worth considering screening the child. This is the CDC's algorithm for evaluation of congenital Chagas disease in infants less than 3 months of age. So if a sample of cord blood can be obtained, then microscopic examination using a Giemsa stain to look for T. cruzi trypanostomos can be done. PCR, but again, this has been done primarily by the CDC. Although there may be some newer options or alternatives now. And then Chagas disease serology, if the mother had not been tested prior to pregnancy. And basically then if the baby tests positive, then they should be evaluated for treatment. If it's not possible to do cord blood or it's not considered at the time of birth, then an alternative is to test at 4 to 6 weeks of age. But once they get to be older, the 9 months, then it becomes serologic testing. So early, it can be Giemsa stain and PCR, but much later, it will be serologic testing. And again, with two tests, as I've described for adults. That's just highlighting the serology when they're older. And this is for infants that are born to a mother with Chagas disease, but they are not tested within the first 3 months. And basically, it's serologic testing. They should have a screen done. If it's positive, then they need to have a confirmatory test done. But again, it need to be at least 9 to 12 months of age before this is done. These are guidelines that a group of us put together, a couple of, not really guidelines, I guess I'd say recommendations for screening and diagnosis of Chagas disease. And there's this number of different groups, but I think two of the most important are people who are born and live for a prolonged period, defined as 6 months or more in areas of Mexico, Central or South America, where there's endemic Chagas disease. Sorry, I'm right across from the hospital, so if you're hearing a siren in the background, they're not coming for me. And then women of childbearing age, who really are sort of part of the same population, and there's really strong evidence for screening these populations. So I'd like to say a few words about a program that colleagues of mine, Julia Kohler at Boston Children's Hospital, and then Jen Mann, who is now at MGH, Massachusetts General Hospital, developed. And this is called the Strong Hearts Program. This is a screening program that was developed at East Boston Neighborhood Health Center about 7.5 years ago. And the goals were to educate providers, but also to reach out the community and raise awareness of Chagas disease in immigrant communities, screening and treating, and then providing community-based social support. Um, and some of the target populations were children under 18, and then women of childbearing age. Children tend to tolerate the treatments, benznidazole or nifurtimox, somewhat better than adults, and so it's good to treat early. And then screening women of childbearing age to prevent congenital transmission is important also. And then they plan to offer screening to all adults less than or equal to 50 years of age. Reality is they've I think been screening everybody, because occasionally I'll get adults that are in their 60s that have been referred, that have tested positive. Once they are confirmed with a two-step process, two different serologic tests, then they're referred to our clinic at Boston Medical Center for evaluation and potentially treatment. This is a little bit blurry. This is actually from an abstract that was presented at IDSA this year, but I thought it'd be helpful to sort of give you a feel for the flow. So the screening test is ordered. If it's positive, then a confirmatory test needs to be done. They too, like our laboratory, will save a sample from the initial blood draw. Early on, we're having to call people back in to get a second blood draw, and realize that that was very inconvenient for the patients and was, potentially would, lead to incomplete testing. Um, and they had one provider responsible for ordering confirmatory tests for all positive results. So they basically had a Chagas disease champion. Really, it was a team, but primarily Juanuco was very much involved in doing this. If the second test returned positive, then they had someone responsible for referring confirmed cases to infectious disease at Boston Medical Center. They also had a sort of like a Chagas, caseworker, someone who could help with facilitating appointments and making sure patients made it over to see us. We would then evaluate the patient, physical exam, labs, medical history, EKG, and then transthoracic echo and everybody, as well as additional tests as needed, and then decide whether they needed to be treated. You can see between March 2017 and May 2023, there have been more than 14,000 patients screened, median of about 572 per quarter. Overall, Chagas prevalence is 0.7%, so relatively low proportion. I have to say that I work with, through GeoSentinel, work with three different sites in Spain, actually four now, but three that see a lot of Chagas patients, and they tend to have a much higher prevalence in Bolivian migrants. But we're looking primarily at people from Central America, El Salvador in particular. And oops, sorry, I jumped ahead there. Well, there's no gender difference in terms of, no sex difference in terms of distribution. In this analysis, the team also tried to look at the continuum of care from a positive screening test all the way through treatment completion. And so, oh, sorry, I got to go back up here. Sorry. So they had 102 that they evaluated. 94 ended up having the confirmatory test done, so they lost a few there. And then most of those patients, 95%, were notified of their positive confirmatory tests. And then of those, most were referred for treatment. And then much lower, there's sort of a drop off there with initial ID appointment completed. Some of this is, it just takes time to get into the clinic, and there may be a lag time of a few months. And we've worked on strengthening communication to try and avoid losing anybody. And so they have a sort of a Chagas, sort of caseworker. And then we have one of our clinic case managers that helps, who speaks Spanish, is from Colombia, And she gets to know all the patients and helps to make sure they have their initial appointment with us, but also any follow-up appointments like a transthoracic echo, for example. Um, and then you can see that treatment was given in 52, so a little bit less than about half of all those who were screened initially. But not everybody qualifies for treatment, and nor is everyone willing to begin treatment. I mean, it's rare for us to have people turn down treatment. A few people have out of 150 plus that we've evaluated, but not too commonly. Getting through treatment's not easy. Benznidazole has a number of side effects, and not everybody's able to complete treatment, but we've developed a number of strategies to try and optimize that as much as possible. There's some important barriers to screening and treatment. The most important is if you don't think about it, you don't test for it. So if physicians aren't aware of it, then they're not going to be considering it. And so at Boston Medical Center over the last couple of years, we've done widespread education, family medicine, pediatrics, sort of the NICU, general internal medicine, of course, cardiology. But if when they're being seen by cardiology, it may be a little bit late in the spectrum of disease. There need to be guidelines, and there really are relatively limited guidelines, although the recommendations that we published in JID a couple years ago are very useful. Another barrier is the need for screening and a confirmatory test unless they can be done in the same laboratory, maybe confusion about which test to use. And then there are also important patient barriers, limited knowledge or awareness of the disease. They may have challenges in taking time off from work, obtaining childcare, or simply just getting into their appointments. So just last couple slides, why screen? Well, preventing vertical transmission is one real key part. There is some evidence that disease progression may be slowed with treatment, and I believe Dr. Coyle will talk a little bit about that. But also, even if they don't qualify for treatment, careful cardiac evaluation and interventions can be life-saving. So management of dilated cardiomyopathy, with afterload reduction and so forth, but also evaluating for potentially life-threatening arrhythmias, and then potentially anticoagulation. So we work very closely with cardiology on our patients to try and reduce their risk for stroke and sudden cardiac death. So just a couple of take-home points. There's a large number of people living with Chagas outside of endemic regions. It's important to think about the disease and screen all these people. And the challenge is the cost of screening. And so if it's really not feasible to have a full broad-based population-based screening, then targeting women of reproductive age and their infants is important. We have developed a number of resources. So our website is it's at bu.edu Chagas. We've developed a handbook for screening, which we've just finished updating. That sort of walks health centers through sort of what you need to have in place and the importance of having a Chagas champion. More background on diagnosis. There's really, and some of the algorithms that I've just showed, these are all available for free download from this website. We also have some posters that can be very useful, such as the one to the right here. And just a couple acknowledgments, and then I'm all done. A lot of people are involved in our program here. I have to acknowledge in particular the Strong Hearts program, Julia Kohler, Juan Wanuko, Jen Mann, Jillian Davis, and the rest of the team. On the BU side, Dan Burke, Elizabeth Barnett, and Pediatric ID, Natasha Hochberg are really key. We end up managing a lot of the patients, adult and pediatric. And then Maya Carrion and Maddie Dauphiné, who's been our program manager, have been really key part of it, as well as others in the list. And Claudia Jelinas is our sort of Chagas case manager. I mean, that's not technically her title. She's a case manager for a clinic, but she's taken on helping with all the Chagas patients, establishes a good relationships with them, helps them get to their appointments, helps them get food if they have food insecurity. She's really fantastic. And then we also work closely with our pharmacists during the process of treatment. And finally, I'd like to acknowledge Sue Montgomery and Emily Dodd, who've provided funding for our cooperative agreement, and one or two slides as well. So thank you very much. I'll stop there.
Thank you, Dr. Hamer, so very much. We are going to go ahead and transition over to Dr. Coyle. And again, we will have time for Q&A at the end. But if you also have questions, excuse me, for Dr. Hamer or any of the speakers, please feel free to put them in the chat, and we'll do our best to answer and then have another Q&A at the very end.
You see one or two slides?
Two.
Okay, let me just change my, how's that? Better?
Same? Still the presenter view.
Still the presenter. Maybe I'm in the wrong one. Hold on.
Mhm.
I had to share. Let's see how that works. That looks like maybe here. One, maybe?
One. You got it.
Ah, good. There's so
Mhm.
many slides so many things. Okay, so I'm going to talk about treatment, and I was asked to keep it simple, and I, as usual, did not listen to my instructions. So that's that. Sorry, Paula.
That's why we
So,
love you, Chris. That's why we love you.
and I have 75 slides for, I think, 20 minutes. So, put your seatbelts on. I have no disclosures. And it's not that I'm going to go through this again. And thank you, David, for doing such an excellent job. But what I'm going to start having you think about is thinking about when you're thinking about treating a patient, where are they in relation to their acute disease, and where are they in relation to whether not they're an indeterminate or determinate disease. And so when we think about acute disease, we always think about it as the individual getting disease when they're in the endemic region, getting a bite from the reduvid bug. But remember, congenital and reactivation are both acute diseases too. And so when we talk about acute disease, we're always treating somebody that we diagnose in acute disease. And so we're talking about screening today and potentially identifying children, neonates that are infected. And so that's important. And then, of course, individuals then go into this indeterminate form. And what I'm going to do for you with treatment is I'm going to break that up. And that's basically when you go from, and I'll show this again, when your parasites in your blood smear are no longer detectable on a blood smear. And now, yes, if you PCR'd someone every single day, it might be positive, but you revert to establishing the diagnosis, as we just heard with the diagnosis, and I mean with the serology, and you heard that David talked to you about the problems with that. And so when we look at the studies, we're going to break them up into those studies for those individuals less than 18 years in the indeterminate form, and those individuals 18 to 50. So they have no signs or symptoms of Chagas disease. And as you also heard of them, about a third will go on and progress to determinate disease. So I'll go over some studies in determinate disease with you too. So I'm going to break this up that way, and that's the way you're going to think about it. Someone's bringing in a cup of coffee for me, so let's have a moment with that. Thank you so much. This is service. So when we think about acute disease, and we just talked about this, there is the parasitemia is very high. We can find it on parasites on the blood smear. If we do a PCR, we can find it's positive. But over time, and that's about the first 2 months, it will go down to where your blood smear is indetectable. And that's this chronic phase, or this indeterminate phase that David was talking about, where we diagnose with the serology. And I just want to remind you, because I'm going to be talking a little bit about what do we follow when we treat somebody. And that's what this slide is going to be about. I will remind you, because we'll speak just 2 minutes on immunosuppression, that when we immunosuppress individuals, we can see that the parasitemia rises just as it does in acute disease. And we always treat individuals in both the acute phase of disease and also in reactivation, because it is like acute disease and there's a high burden of parasitemia. Okay, so I think that was it that I wanted to say on this particular. Oh yeah, that's what I wanted to say. So when we think about endpoints for treatment, when you're in the chronic phase, right here. Your endpoints for treatment would obviously be developing cardiac disease. But David already told you that can take decades, and not everybody develops cardiac disease. And I'm going to focus on cardiac disease. And so, I already just said to you, PCR may or may not be positive. So a negative PCR, a reversion to a negative PCR, is certainly not helpful when we're looking at studies as an endpoint. But if somebody continues to have a positive PCR or there's PCR positivity, that will tell us that there's failure. So we're stuck now with a disease that has not great endpoints for us to study. So I just want you to think about that when I'm going over the studies that exist. And there's not many when you think about it. There are two drugs, benznidazole or nifurtimox. Most of us on this call that treat patients have the most experience with benznidazole. They were both developed in the 1960s. Benznidazole is approved for 2 to 12, nifurtimox approved for birth. And although we use them in adults, and I use them all the time, it's most effective during the early infection. And I think David really underscored this. They're difficult to tolerate. So the older you are, the more difficult it is to tolerate it. And there are frequent side effects that we have to manage, especially in adults. These are oral medications, and they're taken for 60 days. There's no test to determine successive treatment. And I just went over that with you. Anti-trip treatment, there's clear efficacy in acute and congenital infection. And I keep on saying this, treatment in acute phase is the standard of care. Early infections are rarely detected though, especially if you're not doing screening. What's important for you in the chronic phase, when we talked, and I broke that up into 0 to 18 and then 18 to 50, age is really used as a proxy for duration of infection for those of us that care for these patients. And conventional serology can take decades to respond. So the earlier you are seeing a patient, their median time to negative serology will be, so if you're under 15 years of age, it will revert quicker than if you are older than 15. It will take up to 27 years. So this is hard when you're in a study to make that an endpoint, and I'll show you that. PCR reversion is not a cure, a test of cure. I told you that, but PCR positivity is a treatment of failure, is a sign of failure. So let's talk about children, and that's that indeterminate phase of up to 18 years. So 2 clinical trials in children 6 to 12 years, both used benznidazole, and the primary outcome was reverting to seronegative using lytic antibodies and xenodiagnosis. The effect on cardiomyopathy, so the long-term effects, were not measured. And so just we're not going to get down in the weeds on this, but you're just going to get sort of an overview. This is like hors d'oeuvres. And so the first study that I'm going to go over with you was published in 1996 in the Lancet with Andrade as the senior author. And it's a double-blind RCT in children in rural Brazil, ages 7 to 12, asymptomatic in our indeterminate phase. Benznidazole was given for 60 days versus placebo, and the follow-up was 3 points. The primary endpoint was negative seroconversion at 3 years, but the secondary endpoint, because we know that negative seroconversion is a hard primary endpoint to achieve, was reduction in antibody titers. So 55% effective, so with regards to disappearance of antibodies, but there was a significant decrease in ELISA at follow-up in the benznidazole treated group. So this disappearance of antibodies was in the benznidazole treated group. The second study was a double-blind RCT in Argentina. And at that time, there was a heavy surveillance and insecticidal use in the region. And so the authors pretty much felt that most individuals that were enrolled in the trial, the infection was at least 6 years. And that's important because I keep on driving home, the closer you are to the initial infection, the better it is. Children were young, ages 6 to 12. There were 51 children in the benznidazole group and 55 control. And the follow-up period was 4 years. And there was serologic and xenodiagnosis at the end of treatment. Oops. In case you don't know what xenodiagnosis is, basically what happens is a virginal rejuvenated bug is allowed to feed on an individual, and then they're followed up to see if they ultimately become infected with Chagas. So that's pretty complicated and takes a lot of effort, as one can imagine. So here, if we look at this, here's your benznidazole group, and here is your placebo group, and you can see your benznidazole group had significant seroconversion, although not completely to negative, but it was pretty impressive. And here we look at individuals that were placebo with a xenodiagnosis, and 51% were basically positive in the group with placebo, and only 4.7 or 5% in the benznidazole group. So this is pretty impressive studies. And so they changed the standard of care for children, and we treat all infected children. And again, there's still no widely available test of cure. So, and that really is an issue. So what I'm going to do is I'm going to keep on adding who to treat, because I feel like at the end of lectures, I give this who to treat, and I rip through it, and I expect you to put together everything that I just said. So every time we learn something from the studies, we are going to add to this who to treat. So we all agree we're going to treat acute disease, that's congenital, reactivated disease, and acute disease. And then children less than 18, we have 2 RCTs to basically support that. What about adults? What happens to them? Let's look at these folks that live 18 to 15 years or may not progress to cardiomyopathy. What data is there out there? So the data on adults is really less secure. And for everything I just told you, the serology takes decades to revert to negative. And PCR, again, is a good indicator of treatment failure, but not of cure. So it would be really great if we could have a study that shows treatment delays cardiomyopathy. There is an observational study that suggests that treatment prevents delays in cardiomyopathy, but it is quite flawed. And then I didn't go over all of these. Benznidazole is associated with parasite clearance. There is a recent study on that. And so I will show you that. But most agree that the earlier in the course of treatment, the better. And that's important when you think about screening and prioritizing your screening, which makes it difficult. And we're working with different centers on setting up screening, and this becomes an issue on how do we start it, who do we start with? So what about decreased progression to cardiomyopathy? So there is this Annals paper from 2006 where they had done in Argentina. And so they looked at individuals who are serology positive, no heart failure, and 283 had benznidazole and no treatment for 283. And they were followed for a mean of 14 years. The primary endpoint was progression. This was a non-randomized trial. Okay. And so basically, when they looked at here's your untreated and your treated, they basically looked at a Kushner score, and they found that those individuals that were untreated progressed more than those that were treated. But there were a lot of problems with this. It was non-random, unblinded, treatment assignment was unblinded treatment assignment was not used. Follow-up data was missing for at least 20% of patients, and loss to follow-up was more common among patients who were less sick. So this is problematic, but it's the data that we have, so I present it to you. What about lowering mortality? There is a recent study on mortality, and this is an observational prospective study in Brazil. And so it was 18,800 patients about, and so 493 treated, 1320 non-treated. But this is the important thing I want to show you, because we're going to start looking at some older patients. 83% were less than 40 years of age and got at least one course of benznidazole in the treated group, and the primary outcome was death at 2 years. But their secondary was cardiomyopathy or markers of cardiac worsening, worsening BNP, changes in EKG, and PCR positivity. And so when they looked at that, and you can see here that that when they looked at the benznidazole group, there was a decrease in mortality, 2.8% versus 7%. And there was also a delay in development of your cardiomyopathy, or the cardiomyopathy markers, if you will. I know there's some cardiologists on here and they're cringing. Women of childbearing age. So we know, and I didn't put all the studies here, but there's some small observational studies to strongly suggest that you eliminate congenital transmission for future pregnancies, decreases the risk of placental passage, and there's health benefits for the mother because for the most part, many of these individuals are younger. And of course, for the other siblings at of this baby. I wanted to just say when you look at decreased risk of transplacental passage, we do not give treatment till after pregnancy and after breastfeeding if we are screening women of childbearing age or pregnant women, in which I'm going to talk to you about. So, what do we make of all the data that I just showed you? Well, we already went over acute disease. We already have some disease, 2 RCTs on children less than 18. And this is our data on indeterminate disease. And so the data is less clear, but is definitely certainly that the younger you treat someone, the better. And we definitely want to treat our women of childbearing age. So what does CDC say? They say generally offer in this age group. And you can see why they say that. Once there's involvement of the heart, and by the way, happy Valentine's Day, will treatment help stop progression? And this is, I think, the study that we have. It's a randomized control study of benznidazole for chronic Chagas cardiomyopathy that was published in New England Journal in 2015. And they basically looked at 1,000 patients, 500 in each arm, benznidazole versus placebo, and they had a primary outcome and then secondary. And so I'm just going to show you the groups first, and then we'll go back. Their co-primary endpoint was this PCR, and we've already discussed that. So I'm going to leave that for this particular lecture. So let's look at who they picked. So they basically picked, almost all of their patients in New York Heart Association Class 1 and Class 2. So these are very early heart disease, heart failure. And when we look at the patients, I want you to see that there was no difference between the groups statistically, but the mean age was 55. So these were older patients, and that's very important. And many of them actually had very preserved EFs. So when we looked at their individual endpoints, like things that would happen to people with Chagas cardiomyopathy, and we know this is a very arrhythmogenic disease. So sustained VTAC, getting a pacemaker, going to heart failure, cardiac transplant, there was no difference. When they looked at a composite outcome, a sort of cardiac composite outcome, and they looked at a 7-year follow-up, there is no statistical differences, and the curves are really almost overlapping. So this did not reduce the rate of the primary outcome despite reduction in parasite detection. There was some changes in PCR. So this suggests that benznidazole may not be as effective in patients with cardiomyopathy. And so when we'll talk a little bit about that. So this is what CDC says based on everything that I just told you. You're definitely going to treat your children up to 18. They want you to treat congenital, and treatment is strongly recommended for adults up to 50 years old with chronic infection who do not already have advanced cardiomyopathy. And so obviously it should be individualized. And so we had cardiac disease here. So we normally manage the cardiac disease, but remember, those are very early cardiomyopathy, the patients that were enrolled in the benefit trial that I just went over with you. And they were an older group of patients. So we do not have data on patients with very early, like somebody with a right bundle branch block and who's younger. So we just don't have any data on those individuals. So again, that remains sort of a black box. When we evaluate a patient, we get their baseline EKG, their echo, we do ambulatory cardiac monitoring, we consider an MRI here, and we do baseline testing. And so let's put your knowledge to a test and look at a patient that we saw here. I just want to keep an eye on my time. And so this is a 33-year-old, no past medical history, admitted after sudden collapse. He was found in VFib. He was actually working in a restaurant, and they were able to shock him immediately and achieve rhythm. And so he was not intubated and did very well. He was originally from El Salvador, migrated through Texas 18 years ago, and works in the restaurant. no family history of cardiomyopathy or sudden death, and interestingly enough, had been playing soccer just up until up until the day of his, so looked pretty fit. He really did not look like somebody with cardiac, the way we imagine somebody with cardiac disease. This is his EKG. You can see he has a right bundle. He has ectopy. There we go. And this is his echo. And we can see he's got lots of inferior lateral, lots of inferior hypokinesis. Oops. Oops, oops. Sorry about that. He had a cardiac catheterization that showed non-obstructive coronary artery disease, right? And then he had a cardiac MRI, which is really very telling and tells us maybe why the benefit trial didn't really show an effect on late cardiomyopathy, although they didn't really have late patients. But the EF was 40%. There was hypokinesis. But the important thing here that I want to show you is that he had myocardial edema and lots of scarring. And as Shakespeare says, what has been done cannot be undone, right? So if there's scarring, that is not going to be undone. And so the T-Cruzi was positive, and he basically underscores everything that we think about with cardiomyopathy, and it occurs in young individuals, and it's very arrhythmogenic because it loves the bundle branches. He didn't have an apical aneurysm or a stroke, but that's something we do really worry about. But he had a dilated cardiomyopathy with segmental wall abnormalities in the inferior lateral. Like literally, he just read this textbook, and obviously cardiac arrhythmias. Would you treat him? So when you think back, although older patients, we know that he would not be somebody that we would treat. I just want to remind you that in immunosuppression, this can reactivate, and it's very important. And again, there is increased intracellular replication and return to that high parasitemia we see in acute disease. And so you have to remember this. You're going to get a talk on HIV co-infection, and we see it mostly here in New York with our cardiac transplantation. And this is a 57-year-old diabetic born in El Salvador, status post a heart transplantation, who presents with just malaise and skin lesions. And there was concern for rejection. And as the transplant people do, they biopsy everything. So they biopsied these skin lesions. This is courtesy of my friend Rachel Gordon. And this is an old case. This is before we were routinely screening. And those are the skin lesions. And here are the biopsies. This is of the heart. And so the transplanted heart, you can see there are parasitophorous vacuoles filled with mastigotes, and these are the antibodies in the skin that are positive for Chagas. So the parasite is everywhere, it's in tissue. And so what we normally do is we don't not transplant somebody, but once we immunosuppress somebody who's transplanted, we check their PCR. And so when you're seeing a patient like that, you're seeing a patient that already has got lots and lots of parasite in the periphery and it's already in the tissue. We don't want that to happen. So after we transplant somebody with Chagas disease, we actually follow their PCR, and if it goes up, it's actually not up, but I won't go over that. But if there's an increase, we basically preemptively treat them. Just remember, this is a 31-year-old with HIV who presents. He's from El Salvador with a very low CD4 count and gait instability, and has an MRI that looks very much like toxoplasmosis. They were worried about missing the diagnosis because of this huge lesion and the shifts. So they biopsied him and they found kinetoplast. And so toxo in HIV patients, unlike in our transplant patients, presents actually with a necrotizing encephalitis, very similar to toxoplasmosis. So very important for us to remember and screen our HIV patients. So interesting that Chagas reactivates differently in different immunosuppressions. In our solid organ transplant, like the patient I showed you, we get these skin lesions and we basically get involvement of the heart. We don't want that to happen. And in HIV patients, we really get more of these CNS necrotizing encephalitis that mimics toxoplasmosis. Let's move to congenital disease, and we already went over that. I took out my diagnosis. So basically what's important to you is that it's estimated about 22 to 108 infected infants are born each year, but remain undiagnosed. They appear healthy at birth, but untreated, they also are at risk for developing life-threatening cardiac or GI manifestations. And only 10 to 40% of infants will have clinical signs at birth. So most individuals will not get diagnosed. And so when you look at signs of congenital disease, you can see that prematurity, hepatomegaly, splenomegaly, petechiae, these mimic other congenital diseases. And one may not think about this if we don't think about the mother's country of birth. So treatment is always indicated. And of course, if the mother is diagnosed, she and her children, her children, her other children should have serologic testing, and the treatment is always indicated for the woman in childbearing ages for the reasons that I went over. So what are we doing in New York? And I'll do this quickly. I'm working with Nancy, so she's going to go over that. So I didn't go over that. We started at New York. I'm part of HC, Health and Hospitals. We are the largest safety net hospital system in the country. And we have 11 acute care hospitals, and we serve mostly an indigent and also migrant population. So we started at Elmhurst because they had done a serologic diagnosis study back in 2013, where they looked at 75 people in there, and they served, by the way, this is in Corona. It's in Elmhurst next to Corona, Queens, where they got hit hard and early with COVID. But before that, they have a really almost universally, except they have a Latino population. And in fact, nobody speaks English as a primary language in their clinics, I would say. So in their cardiac clinic, they ended up looking at patients that were born in endemic regions and found that 13% of them with non-ischemic cardiomyopathy had Chagas. So I thought this might be a good place. I also do clinic there to actually do screening and obstetrics. And so the most important thing about all of these screening projects that you've heard or going to hear about is you need a champion. And David said it, and I'm going to say it, and Nancy's going to say it. So I found a champion. They had been doing a Zika project. Everybody was already asking the country of birth. So all we did was, for those individuals that were born in Latin America or Mexico, they were given a serology. And if they were positive, they were immediately sent to my clinic. And then we did have to do a second blood. At my hospital, we don't, but we were unable to store the blood because they saw so many patients there. We basically have, this is what we did. Let me just let them know that I'm sorry, this is my phone and I can't disconnect it. So this is what we did. And we looked at almost 5,000 patients. And you can see the majority of them were from Ecuador, Mexico, and Colombia. We have mostly Cuencans that are in this region of New York. And so not a lot of Chagas there. And so interestingly, we found 4 patients that were confirmed positive. We only screened 10 El Salvadorians, and of the 10, 4 of them were positive. All infants born to the positive mothers tested negative, and we tested all the siblings. We then got called by Sue who let us know that Glen Cove sounded like they were doing a lot of testing, and they're part of Northwell. And so we reached out to them, and they're a family medicine clinic. And it was a lot different than working with Nancy, and she's going to talk to you about her experience, because they actually have an obstetrician on site and they have a cardiologist on site. I'm so sorry. This person is going to keep on calling. I'm sorry. I'm giving a lecture. Can you call back? I'm just going to keep this off, guys. Sorry. So that was an easier, in many ways it was, and they were able to save the blood there. So that was really much easier. So we developed site specific guidelines for them that were very different than Elmhurst, because Elmhurst was basically seeing huge numbers of OB patients. The lab was on a different floor. They were not as well connected. This was a little bit easier to get started from that. But again, everybody except for my OB group, because they just have it plotzed into another project that they're doing, everybody is, having problems with being, with all the work we do with the clinical work. And so this was our flow chart for this group that we work with on them. And this working on these flow charts takes really quite a while, weeks and weeks. And so we did multiple different things. We put it into the Epic. We put little smart phrases into Epic. So we did all different things with these clinics. And so one size does not fit all. You really need a champion. And every time I've started a screening project, I've had to figure out what do they do? How do they get their bloods? Who gets their bloods? How do they call patients back? And really tailor it to each of their clinics. So now we're doing Chagas diagnosis in cardiology clinics in HHC. And we've been really lucky because Bellevue Metropolitan and my hospital have cardiologists that are interested in doing this. Elmer's is feeling a little bit stretched, so we can't do it. We've done a pre and a post. We're going to do a post test. So we've done a pre test, and we've had Rachel Marcus give grand rounds to all of the hospitals involved. And we've done educational sessions to train providers. By the way, all of these projects we meet on some type of a monthly basis so that everybody can talk about what their challenges are and what their successes are. And then in this project, we distributed Chagas screening cards. And so this you wear on your ID, and it says, I screen my cardiomyopathy patients for Chagas disease. And then it says which findings are suggestive. And we put this on the back of the card. And I think I was going to do one more case, but I really want to give some time for everybody else. So I'm not going to do another case. So I'm going to leave it at that.
Thank you, Dr. Coyle. That was amazing. A bit of a fire hose of info, which was incredible. I always learn a lot from you. And I bet people always actually probably have questions, but maybe we'll let them absorb that for a moment while Nancy talks about what she did, because I think it's going to be really relevant to what you just discussed in context. So thank you very much. If you all have questions for Dr. Coyle, if she's gonna, are you able to stick around for a few more minutes? Okay, go ahead and throw those in the chat. I'm going to turn it over to Nancy, and we're going to get started so you can understand how this program reflects in how she's doing it there.
Thank you. I'm going to put my speed on 2 notches slower than Dr. Coyle. But actually, this will be a nice overview, I think, and hopefully pull together some of the things we've talked about. I want to start really by thanking the organizers of ECHO and also CDN for their continued support in this educational initiative focusing on Chagas. And Paula's work has really been so impressive and impactful in bringing to light Chagas disease and also bringing together people from really all over the country that are ready and willing to talk Chagas. And certainly I've appreciated Dr. Hamer's willingness to share all he's accomplished in the way of screening in Boston and making the handbook. I haven't seen the updated version yet, but available in terms of helping us guide practices for screening. This is a list of our team at Sunriver Health. We were really lucky and grateful that Dr. Coyle was enthusiastic to join our team, and her leadership really throughout our screening effort, along with Dr. Montgomery, has made our initiative possible. For those of you who attended the ECHO session about a year ago, you heard about our planned pilot project. So now you're going to hear a little bit more a year later as we've begun our process of screening. And if you can go to the next slide, please. Our FQHC, Sunriver Health, we've had many different names over the years. We started out 50 years ago. In fact, as we approach this milestone anniversary, we're celebrating the fact that in our beginnings, we were a single rented room with one physician back in the 70s, and we now have, in fact, 51 sites up and down the Hudson Valley, New York City, and Long Island, and we serve about 270,000 patients, about a third of them having been born in a different country than the US. Next slide. So our Chagas project was really driven in part by discussions over the years with my GeoSentinel colleagues, such as Dr. Coyle and Hamer, because in the 20 years that I've been tracking infectious diseases in our migrant population, we only had in our database one case of Chagas who happened to be a gentleman from Mexico who donated blood and then got a letter in the mail that he had Chagas disease and came to us for treatment. So why so few? Well, we weren't screening, we weren't looking for it. Chagas was not in our radar. But as an FQHC without mandates or funding for research, although we've done research over the years in collaboration with CDN, when we decided to begin a Chagas screening project, we really wanted to frame it as a quality improvement project, avoiding the need for IRBs and other administrative issues associated with prospective research. So we opted to present our project, and we talked about this on the last Echo series last year as a quality improvement project. And we went to our Quality Improvement Council and presented it, and they gave us the green light to go ahead. Next slide. Can you go to the, yeah, thank you. So we needed to organize the pilot. We needed to choose a site, obviously, in our 50 among our 51 sites. And we needed to put together a team. We needed to train and educate team members, staff, and also we needed to work with our informatics in order to create templates and tracking systems. Next slide, please. We really opted to start small, and I'm so glad we did. We didn't want to say, okay, let's just start screening everyone from endemic areas for Chagas disease. We would not have been able to handle that. So starting small was a real key for us. And then finding the appropriate population. Obviously, we wanted to go to a site where we had, and mostly all of our sites do have patients from endemic areas. I thought it would be great to really hone in on prenatal patients. This is a captured audience who comes in regularly, and in New York State, all pregnant women have health insurance. There's also a greater ease because they're coming back and forth to our center in terms of tracking. Our mission focus was pretty obvious. As we all know, this Chagas disease has a great impact on lives, and treating the young mothers, as Doctors Hamer and Coyle have talked about, is so important, and certainly treating the babies to avoid any further issues in health going forward. And one other really important piece in our pilot when we put it together was really getting leadership buy-in. We had a zero budget and we haven't asked for any money. We've done this it's our passion project. But we've really kept the leadership, initially when they gave us the green light, but we've kept our CEO or CMO or CFO, all those C's, really updated on what we're doing and how we're doing. You can go to the next slide. So you saw this slide a year ago when I went through, fortunately in our EMR, we do ask every patient that walks into our health center what country they were born in and how long they've lived in the States. And so I went to our Brentwood site, which is one of our sites in Long Island, and I looked at the obstetric population, which at that point there were about 100 patients. And as you can see, all but three were from either Central or South America, with the largest majority from El Salvador. So that was the site that we decided to start our screening. Next slide. So we started by building a collaborative team, and as Chris just mentioned, really driven by you need a champion, and we have several champions at that site, and we put that group together. We did a lot of training and education amongst the staff, which included the nurses, the providers, and the community. We realized we had to rely on the guidance from experts, and that's why we were so fortunate to have both Doctors Coyle and Montgomery as part of our team as we created the protocols both for screening and tracking. And our informatics is quite robust, and they helped us create templates so that we were not just asking our patients where they were from, but we were honing in on other issues about how they grew up. Was their bathroom outside? What type of housing did they live in, to kind of get an idea of what their risks might be. We work with our patient navigator also, organizing a system to bring in family members and spouses for screening of any of our positive confirmed patients. Next slide. So in September of 2023, we began screening at our Brentwood site with our prenatal patients. Next slide. And the process was that simply adding T-Cruzi antibodies to the prenatal panel. So that piece was easy. Our commercial lab BioReference then would do the ELISA test, and if it was positive, it would then come back, and we'd have to redraw blood, and I'll talk about that in a minute as a barrier, and send it up to our state lab, Wadsworth, for a second ELISA. If there were discordant results, then we would send it on to CDC. And as already been mentioned, that as of December 2024, the testing, the confirmatory testing has been paused. And so Wadsworth now, our state lab, is currently conducting confirmatory testing on those that have discordant results. To date, we've screened about 788 prenatal patients. Next slide. So our positive screenings, we've had 6 patients that were screened positive with the commercial lab and 3 confirmed positives, all from El Salvador. We're awaiting 2 other confirmatory tests, and one of the patients that screened positive returned home. Next slide. This study was from Catalonia that Dr. Coyle pointed out to us, that was published in 2019. I believe it was a study over a period from 2010 to 2015 in Catalonia, where their cohort was quite a bit bigger, over 30,000 pregnant women from endemic countries who had lived in rural areas. And David already mentioned the high incidence in Spain, and the high number of Bolivians there. And as you can see in this particular study, the Chagas disease overall in the screening was found to be about 2.8%, but rates were highest in women from Bolivia. And secondly, El Salvador, which is kind of our population that we're seeing in our pilot. So that sort of lines up. 28 infants in this study were diagnosed with congenital Chagas. We haven't been able to look at transmission rates with the positives that we've had, just because our deliveries are outside of our system, and it's been difficult to test babies, do cord blood, or testing babies at birth, PCR testing. Next slide. So just to review, and we've already talked about these, I mean, we're talking now about an FQHC, not a big medical center, but a lot of we have in common with what David already talked about, barriers. In our setting, aliquots, when we draw the blood, cannot be stored. We don't have the bandwidth for that. So this means for positive commercial testing, we then have to contact the patient to come back in. Now, again, with the prenatal patients, it makes it a little bit easier because they're coming back in anyway. So that's helped us in that regard. That's not necessarily the case if any of their family members are positive. Training our staff then for those who tested positive with the commercial antibody test to send to the state lab is a process. And we had an issue a few months ago where our nurse that was doing that work was out, and retraining and finding someone else to do that. We realized without her there, that process came to a halt for a bit of time. And the CDC, as we've already mentioned, is on pause right now for confirmatory testing. The tracking is always not that straightforward. Positive cases need to be called back. We need to get in family members and mothers, certainly after. We have to wait until after they've finished breastfeeding for treatment, and keeping track of all that is a little bit daunting. In the FQHC setting, I mean, we're very lucky in our setting to have 2 wonderful ID specialists, part of our project, but that's not always the case in some of the smaller sites. We do not have cardiology right within our site, so costs that are incurred for patients that need to be referred for cardiologic workups and so forth make it difficult. And it's, the complexity of the treatment we've already discussed, accessing the drug, which we do, it's sent to the patient's home, but we need a lot of education that goes around that and intensive follow-up because of the reactions, the potential reactions. One of our confirmed positives did start the benznidazole, and after a couple of months of treatment, ran into having pretty severe allergic reaction and had to go off the medication. And the costs incurred also with things like echocardiograms, which are not easily available for us. So finally, I'll finish up really looking at our overall pilot. We've come to really appreciate the complexities. We're really very happy that we started small, and we've learned a lot along the way. And thanks to Dr. Fiore, who is in the area of research, implementation science, and pragmatic research designs. If you can go to the next slide. He sort of guided us in putting together an implementation map, which I'm not going to really go over in depth, but it covers a lot of the things that we've talked about, the importance of our team and how we put that together, of the cohort that we're looking at, and barriers certainly. So with that, I'll stop so we have time for questions, but thank you very much for your attention.
Thank you so much, Nancy. That was really good information, especially for those of you, in FQHCs or you're considering starting some screening programs. We'd like to open it up for questions. I know this was a lot of information. If anybody would like to unmute themselves and ask a question from our experts, the floor is yours. Or you can put them in the chat if you're feeling shy. Sometimes that happens. I will say we had a comment from Craig, if you want to read that, about involving ED physicians, emergency physicians. And as I was reading the comment, I kept thinking about it's not a bad idea, if you have somebody coming in, just like these other screening programs we're talking about, and they are from one of the endemic areas. If you do happen to ask of origin of birth, then you might be able to screen them there as part of the workup, especially if they're there for cardiac purposes. I don't know if Chris or David, you have some comments on that.
Yeah, I'll make a quick comment. I mean, I think it's a great idea. The challenge is, making a diagnosis quickly. I mean, there are some, a rapid test available, but you really will need to do a confirmatory test. You're going to need to orchestrate follow-up if you're trying to make a diagnosis in that context. But that said, it's a good idea because, there may be a number of people from endemic countries that are being seen in emergency rooms. I mean, for example, in Massachusetts, like out on the Cape, which is an area that we're trying to get to, there's a lot of people involved in landscaping and construction that are from Central America, but it's sort of a harder population to access. But if they have accidents, they're going to end up in an emergency room. So it's an opportunity to potentially start the screening process, but you really have to orchestrate follow-up.
I agree with that. And, and also on top of that, some of our population at higher risk sometimes use the ED department as their only point of contact for health services if they're especially in states where we don't have universal coverage or really, really poor access to insurance. I know in Texas, that's definitely the case. I like Dr. Panosian's comments or question about evidence of reduced patient encounters in recent weeks or months. I think that's potential. I mean, I think I'm not in the patient care, but maybe David or Chris, or Nancy could respond to that. I think we're still figuring this out, right?
I mean,
Oh yeah.
Go ahead, Chris.
Yeah, I know. I was just going to say, well, we serve only undocumented individuals here, as we do have everyone gets New York City care, regardless of their migration status. I'm just hearing, not through there's a lot of anxiety, but I'm hearing through other people that their patients are telling them that they're afraid to come to visits. I think that's just going to increase with time. And I think people are showing up now, but I do think it will decrease. I saw someone said from Elmhurst, the hospital I showed you, that they're finding that there's a decreased show rate. I haven't found it just yet, but patients are saying they're quite anxious.
I mean, I would say the same thing for us. I mean, so far, I mean, my last couple clinics, pretty much everybody showed. And my clinic, I mean, I do a combined travel tropical medicine clinic. At this point in time, it's 90% Chagas disease patients. And we because we have a Chagas sort of case manager, she calls them up, tries to make sure they're coming. Very few don't come. If they don't come, at least in recent months, it's mostly because of a work problem or they just can't get the time off. But I think there is a lot of anxiety in this community, definitely, about what may happen next.
Yeah, thank you for that. I know, especially in our border states where we're at right now in California, Texas, Arizona, there could be even additional um, barriers. Let's just call them that. So, absolutely, I think that's a great question. Stefan wrote, go ahead.
Yeah, no, I was going to say, Stefan Hagman wrote, is there a chance that the recommendation to screen pregnant patients at risk will be validated by the American College of Obstetrics and Gynecology? Um, I don't know. We haven't worked with them directly. We actually work very closely with we have sort of a point person in obstetrics to make sure, and they have a whole protocol for antenatal screening. So Chagas is part of a routine antenatal screening at Boston Medical Center and East Boston Neighborhood Health Center. But I don't know if there's work going on at a higher level at ACOG to try and raise awareness and make this sort of, something that they would recommend. I don't know, Christina or Paula, whether you know of anything along those lines.
No, nothing. I don't. Yeah. I
No,
think the more that we get screening and we get it into their literature, I think that Nancy, we haven't talked about your group, but the Elmhurst group, I think we want to put it's an OB person as a senior. So we're going to put into the OB literature. So I think the more that goes into their literature by OB physicians, I think maybe there'll be take up for it. I don't know.
I think I've heard lots of different groups talking about wanting to target ACOG as um, a group to get more info. It's just been a little bit difficult to get in there. But I think I feel like I've seen some traction in the OBGYN world with these new, at least I can hear about in Southern California here, talking about screening in some of the clinics for women, moms. And so maybe I'm predicting in the next few years we'll see a little bit more, well, maybe not the next few years, maybe in 5 years or something, we might see some more traction with some of the screening programs going on in the southern states, at least. Maybe watching you all do what you do, I think I'm seeing more people want to pick it up. In San Antonio, I know they've got a couple of maternal screening programs going on. So I think there's some small movement. It's just slow. Great questions. Anyone else have any other questions? Right, Craig put something in the chat. Oh, we've had a lot of discussions with our entomologist colleagues and others about other transmissions so far. As far as I know, they've been mostly just in laboratory setting. We've heard about the bed bug transmissions. I don't think it's something we've been necessarily concerned with, especially here in the United States. We have, what, 10, 11 different species here, most of them sylvatic, a few that are becoming more domesticated. So I feel like this concern of the jump of the parasite to a different vector. I don't think there's enough research out there on that, but I think it's not something that we've been terribly concerned about, at least in the US for local transmission, but for other countries, I can't really speak for that. But we have had some entomologists talk a little bit about that, and um, but I don't think there's a whole lot of evidence of that in a natural setting outside of the lab. But thanks for asking.
And Paula, isn't like your next seminar on this topic? Like,
It's
sort of,
on autonomous transmission and One Health, and yeah,
right. So
definitely
it
gonna
sort of
have some,
overlaps this question to some
mhm,
extent. Yeah.
having some vector and canine studies involved in the next lecture. So definitely some overlap. Yeah, thank you. Just a reminder, we have a evaluation. Please click on that and fill it out, especially if you're wanting CME. And if you need contact of any of the speakers or have further follow-up, please let us know. And I also put my email in the chat. Feel free to reach out anytime if you have follow-up questions. This session is recorded, and we will have the recording posted in two places on the CDN website, also on our UT Health Echo Network site. And I think I've posted in there two links to that as well. I'd like to thank our speakers for your time. I know you're busy, lots of stuff going on. And also thank our, CDN partners, the CDC, and everyone else on our team that helped make this happen. I will say one last thing here. There's a question in the chat. Interesting. So, um, I'm super happy to talk with you about that because now I'm relocated from Texas to Southern California and happy to work with you more. Anybody in California, because San Diego County has made it reportable, thanks to our colleagues at the county health department here. And LA County, it's also reportable. The state of Texas, it's not, I mean, the state of Texas, where am I? State of California, it is not reportable yet, but maybe hopes that as more counties in California decide to make it reportable, so might the state go reportable. We'll see how that is, but happy to follow up with you. And with that, we're 3 minutes over. I want to thank everyone again, and we hope to see you at our next session on March 14th. Is that right? Anybody
Yes,
correct?
March 14th. Yes.
March 14th. Thank you. And we'll see you soon. Thank you again to our speakers. We really appreciate you and all you do.
Thank you.
Bye.